title of chapter 13 in there. So, I said this to some of the group, and I'm going to reiterate it now. Your ATI NCLEX is mainly neuro. Chapter 13 is neuro. I just forgot to type it in there. So we're going to hit hard on neuro. Your tests is only going to be neuro. There's a couple slides on mental health. I think I give you information on like ADHD and autism. Just because we see that so often that, you know, it's good in your pediatric rotation to have general understanding of those two. But we're not going to talk about them. We're just really going to hit on neuro. Test is only going to be neuro. So mental health, you don't have to worry about.
You said ATI or neuro mental?
Huh?
Did you say ATI was both neuro and mental?
ATI, I mean, when you get to like your psych and stuff, it's going to hit mental. But ATI and NCLEX, it mainly focuses on neuro. So that's why we're really zoning in on the neuro.
So you're saying our ATI test is mainly neuro?
No. The test for me is only neuro. So you're gonna have no. You're gonna have no mental. No mental. It's gonna be GI, GU, neuro.
Okay.
The content, chapter 14, that's mental health. You don't need to worry about for this test. Does that make sense?
Yes.
Okay. I know you guys would have like come in and been like, "What are you talking about?"
You said no.
Mental.
Pretty much your exam next week. GI, GU, neuro. Chapter 13. Chapter, what is it? 15, 16, and 13. Okay, so first we're going to talk about assessment of cerebral function, our neural assessment on kids. You know, we want to know the general aspects of cerebral function. You know, kids, a lot of times if something's wrong neuro-wise, we'll see issues with their extremities. So, you know, we want to monitor for observe spontaneous and elicited reflex responses. We're going to take a family history. We're going to do a health history, and we're going to do our own physical exam. So the first thing we're going to talk about is increased intracranial pressure. So what is intracranial pressure?
Pressure in the cranial nerve.
It's the pressure around our brain. Normally it's about 4 to 12 millimeters per mercury, or mmHg. Pressure, it's usually normally it's about 4 to 12 millimeters of mercury. So what are different things that can cause increased pressure in our brain? Which leads to excess fluid, so increased CSF, you know, volume, brain mass, blood, if they have a bleed. What about infants who do you think can tolerate increased ICP better, infants or older kids?
Infants.
Why?
Because they're already big enough.
Bonding of the fontanelles are not formed.
Yeah, their sutures aren't sealed yet. So that allows them to expand. So that's why some of the kids get these huge, almost like alien head, because they haven't closed yet. We worry about our older kids though, because they don't have that safety measure. So clinical manifestation of increased ICP in infants. They'll be irritable. They'll have this high-pitched cry and be very difficult to soothe. I don't know if any of you ever heard a neuro baby cry, but I don't even know how to explain it. It's just high-pitched, more annoying cry, and they're very difficult to soothe. That some of them you worry about going home. Like when I worked in NICU, we had some neuro babies. You know, you worry about them going home because parents, you know, and you worry about them coming in back shaken because, you know, if the stress and, you know, they're very difficult to soothe and things like that. Fontanelles, what are we going to see in our fontanelles? Bulging, intense. Cranial sutures are going to be separated. They can have what's called these sun-setting eyes. And I have a picture of this in my hydrocephalus slide where you'll see, you know, just the eyes are huge and just pretty much the pupils are kind of at the bottom because they have all this fluid. In children, they'll have headache, vomiting. They can have it with or without nausea. You know, vomiting is a big sign of increased ICP for us. Seizures. Diplopia. What is diplopia? Double vision or blurred vision, visual effects. Personality changes. Like I said, they can be irritable and restless. or they can have reduced physical activity, really sleepy and drowsy, and lethargy, have problems following commands, or memory loss. Late signs. So we're at decreased level of consciousness, decreased response to motor responses, and sensory responses, alteration in pupil size. We really want to watch our pupils if we have any neuro patients. Decerebate and decorticate posturing. I'm not going to go too much into that, but those both indicate that there's some damage at some point of our brain, right? Remember, decorticate goes core. That's how I remember it. We don't want to see that. Papilledema, that's swelling of our optic discs due to increased intracranial pressure. What's Cheyenne Stokes respirations?
It's like
It's like
apnea.
deaf.
Yeah, they have
Everything
really
studied
irregular
very
breathing. We'll
cyclical.
have periods of tachypnea and hyperpnea, so increased depth and rate, alternating with periods of apnea. Not good, pretty much. And another big one is what's called Cushing's triad. Cushing's triad is a late sign of increased ICP, and it's a triad of 3 different things. So we have hypertension, not just hypertension though, we have increasing systolic blood pressure and a widening pulse pressure. Does everybody remember what your pulse pressure is? The difference between your systolic and your diastolic? So our systolic is elevating, that's why we have that widened pulse pressure,
What's the difference between the systolic
and the diastolic, because our systolic is the one that's going up, so that gap between the two is getting bigger. Bradycardia, and our irregular respirations. Level of consciousness. Our level of consciousness is a very important indicator of our neurologic dysfunction. Alteration in consciousness appears earlier in progression in a head injury than does any signs or symptoms in our vital signs. So we're going to say alteration in our consciousness before we see changes in our vital signs. So as we know, consciousness is the responsiveness to or awareness of sensory stimuli, and it has 2 components: alertness, so our ability to react to stimuli, and our cognitive power, our ability to process information. So unconsciousness is something's wrong, our brain can't respond, our brain can't function right. So assessment. So if we're assessing our level of consciousness, we assess how much stimuli is needed. Do I just need to walk in a room and talk to them, or am I doing, sternal rubs, trying to wake them up? What's the quality of the response? Are they then alert, talking to me for a while, or do they flutter their eyes open and then pass right back out? And what's the length of the response? So, just to give a little more depth into level of consciousness, as we know, our level of consciousness can rate from mild to more severe. Confusion, they have impaired decision making, they're not alert and orientated ×3. Delirium, they're very disorientated, irritable or agitated. Lethargy, profound slumber in which sleep and movement are limited. We can arouse them with some moderate stimulation, but usually they fall right back asleep once it's gone. Stupor, they only respond to vigorous stimulation. And then coma, we can't wake them up, right? They're donezo. So a very quick assessment, like if anybody wants to be, do paramedic or be out on the field, very quick assessment is what we could do is called an APVU. It's just an acronym for a method to rapidly assess a child's level of consciousness. So A, are they alert? V, verbal stimuli. P, painful stimuli. And U is unresponsiveness. So Glasgow coma assessment. How many people have had to do a Glasgow coma assessment? many of my people who've had neural checks up on Peds or Christine's. So these are used in our patients with issues with consciousness. It's used to quantify the level of consciousness. Score ranges from 3 to 15. 15 would be the best consciousness, as they have unaltered LOC, and 3 is extremely decreased LOC. So this is a picture of our Glasgow Coma Scale. Our Glasgow Coma Scale has 3 categories. And there's 2 different ones. There's one for under 18 months and then older than 18 months and older. So eye-opening. Do they open their eyes spontaneously? Do they open their eyes to noise? Does it make us, do we have to give them pain first? Verbal response. Does the baby coo and smile and is appropriate? When we walk in, does the kid talk to us? Inappropriate, are we having normal conversation, or are they just kind of way out there? Motor response, spontaneous movement, do the older kids, do they obey our commands? Any question on the Glasgow Coma Scale?
Are you gonna ask just different things about that, like what is the response, what's like the point system?
No, I just want you to have a general understanding of the Glasgow Coma Scale, what it consists of and why we use it. Pupils. So if anybody has ever done neural assessment, you always have to go in and check their pupils. Pupils are big, very important during neural assessment. If you ever have any changes in your pupil or your pupil responses, we want to notify this immediately, because this could be something really bad going on. Pinpoint or fixed pupils bilaterally can show brainstem injury, or narcotic overdose. Dilated or large pupils can indicate severe anoxia, or brainstem herniation from increased ICP. If one pupil's off, it's never good if our pupils aren't the same and something's wrong. Nursing assessment. So whenever, consciousness is altered, we want to initially assess the child's responsiveness to the environment, the stimuli, their ability to maintain an airway, to breathe, their vital signs, their pulse ox, their blood gases. What do their blood gases tell us? Arterial blood gases. Or CO2 and O2, which tells us what? How well they're breathing, how well they're perfusing. So we always want to have a baseline neurological assessment. Observe for signs and symptoms of increased ICP. Get an accurate I and O. We have different lab and diagnostic tests that can show us if there's any problems neurologically. I'm not going to go too into depth in all of these. CT and MRI. You guys have all heard CT or MRI, right? We can take pictures of the brain. Lumbar puncture we're going to talk about next. In EEG, how many people have heard of EEG? So this looks at the electrical activity of our brain, right? So what do we use the EEG for? Seizures. Yeah, we hook kids up if we think they have a seizure, we hook them up to an EEG. Major one I want to talk about is an LP, or a lumbar puncture. So this is insertion of a spinal needle into our subarachnoid space between our lower lumbar vertebrae. So for infants, you can see up here, we kind of have to hold them in like kind of this U shape, or this C shape, because we have to keep them nice and still, and it's not very easy, your hands cramp up. And then older kids, they can be sitting, or lying on their side. They should, after this, lay flat for 48 hours, but 4 to 8, not 48, 4 to 8 hours, but with kids, that usually never happens. So normally our CSF should be clear and odorless. White blood cells should only be about 0 to 5. Protein about 15 to 45.
Can you repeat all that?
Clear and odorless. White blood cells 0 to 5. protein 15 to 45, glucose 50 to 80, and pressure 50 to 180. So abnormal, if what's going to happen to the color? Yeah, it's going to be turbid, cloudy. A lot of doctors, when they do it, they get blood in it, which you don't want, but it's hard not to. White blood cells, what's going to happen? Be elevated depending what's going on. It'd be 1,000 to 2,000. A protein can go up to about 100 to 500 if something's wrong. Our glucose, we can see it drop below our blood sugar. And our pressure can go up to 180 or above.
So what's normal pressure range?
Lower than our blood.
The normal pressure range again?
Normal, I think I said, was 50 to 180.
Okay.
I'm debating if I wanna. Do you guys wanna go through seizures or do you wanna leave? Okay. We'll stop there. Those are the seizures, right? What's a seizure?
Periods of abnormal.
It's a shortage in the brain.
It's where we have alterations of firing of neurons in our brain, right? So periods, like I said on our slide, periods of abnormal electrical discharges in the brain that cause us to have that involuntary movement and behavior. They can be classified as generalized or partial. Partial is also known as focal. When they're partial or focal, they only occur in one hemisphere of our brain. We usually have no loss of consciousness, and we only have that clonic movement. Who knows what the clonic movement? When you hear tonic, clonic. Clonics are jerking, that jerking movement that we have. Generalized begins in both hemispheres of our brain. So it spreads throughout the entire cortex and the brain stem. So our entire brain is involved in this one. Partial can lead to generalized. And these seizures have our tonic clonic. So our clonic was our jerking, where that tonic is that rigid with loss of consciousness. Generalized seizures used to be called our grand mal seizures. Febrile seizures, we see this up a lot on peds. Febrile seizures when it's not, if their temp gets too high, but it's more about how quickly their temp elevates. So febrile seizure is children who are susceptible have a fever of 102.2 or higher. And that seizure occurs during that initial rapid rise in body temperature.
Febrile is with the fever.
Febrile, yeah, those are kids that come in with high fevers that have seizures because of them. A lot of people think it's, oh, you get to this certain number and they have a seizure, but it's more how quickly their temp elevates that we worry about that causes the seizure. So these are usually developed within 24 hours of the fever onset and usually last less than 5 minutes. And then what is status epilepticus? Anybody? So this is our prolonged continuous seizure of 30 minutes or longer, or two or more seizures where we don't have that full return to baseline. So pretty much where they're constantly seizing and we can't get them to stop seizing. And this is always considered a medical emergency. And this is common in our very young kids. And then epilepsy is our seizure disorder that's characterized by recurrent seizures. So our etiology and our pathophysiology. Am I going okay, speed?
You're a little
Okay.
fast.
Yeah.
A little fast? Okay. So etiology and pathophys. So like we said, this is an abnormal, we have excessive discharge of those neurons in our brain that lead to this seizure. Most seizures are idiopathic, where we don't know exactly what causes them. But a lot can result from a lot of CNS disorders or defects, such as a brain injury. You know, if we get too much fluid in our brain, if we have increased ICP, it can lead to a seizure. One of my aunts just had, they thought she had a stroke, went in, told her she had a brain tumor, and then the next doctor came in and said she had hemangioma in her brain skull. And they were worried about, you know, any mass that can press on your brain can cause the seizure, so they put her on seizure meds. So there's a lot of different things that can lead to seizures. Another story I have is drug overdose. Have you guys learned about the drug tramadol yet? It's a pain medication for adults. That medication, if you take too much, you can have a seizure. My brother overdosed on that at home and had a seizure at home, and me and my mom, both nurses, they'd be like, oh my gosh, what do we do, you know? Kind of blank out for a second and think, oh yeah, this is what I do. So there's a lot of different things that can lead to seizures. A lot of times there's genetic or familial factors, especially when you see status epilepticus. A lot of times there's a familial factor in there. So our clinical manifestations, our signs and symptoms, you know, it depends on the type of seizure they have and the duration of seizure. Like I said, with our partial, what do we see? One hemisphere, but we see not the rigid, the clonic, that jerking movement.
Oh, it's the clonic?
Yeah, partial, we see our clonic. Usually they don't have loss of consciousness, but they can have memory changes, emotional distress. Generalized, remember we have that tonic and that clonic where there's that rigid and that jerking. A lot of kids just have staring spells, where all of a sudden you'll be looking at them and they'll just kind of stare off, and they're out of it for a while, and then they come back to you, and they're having a seizure.
Is that what generalized? Or just?
That's just a staring spell. Your book talks about a lot of different types of seizures, and I just kind of talk about the generalized and the partial, and then touch on the febrile and those staring spells. Whenever I take care of a child from Walter Lawson's, a lot of them have different things that they do when they have a seizure that, you know, you might not know they're having a seizure unless you know that's what they do. So, you know, with a kid with a seizure disorder, whenever I'm taking care of them, I always find out what do they do when they have a seizure. So I know what I'm looking for, so I know if they're having a seizure or not, and what to do. Then we have what's called a post-ictal period. Post-ictal period always occurs after somebody has a seizure. And this is when they're very lethargic and drowsy, and it takes them a while to kind of get back to normal. And the length varies from person to person, how long their post-ictal period lasts. So what are some seizure triggers? Yeah, lights are big ones for kids. Last semester we were checking pupils on a kid with seizures, and he started having a seizure on us because the light. He kept having seizures because of video games. So we had to take away video games. Remember like when Pokemon came out and that like bright, kids started having a lot of seizures. So assessment. During a seizure, what do we want to do?
Get them on their side.
Get them on their side.
Padding around there, prevent injury.
Well, yeah, our seizure precautions, whenever a kid does have seizures, they come in, we make sure we have suction at the bedside, oxygen set up, wool socks on them, and padding the bedside. But if they're having a seizure, what do? We said turn them on their side.
Leave.
Prevent
them.
injury.
Yeah, that's our number one thing. We want to prevent any injury. We're laying on the side. We're going to protect them. We're not going to put anything in their mouth. Biggest thing as nurses is we want to, and this is one thing I always forget, time it. Because when they're having a seizure, the last thing you think is looking at the clock to time their seizure. But you want to time their seizure to see how long it lasts. You want to always document what they do during their seizures. What happens? Do they lose or do they lose consciousness? You know, do they have tonic-clonic movement? You know, what do they do during their seizure? So we're going to note the duration. Did anything happen before that caused the seizure? If possible, you check their pupils too. Like I said, our big thing during the seizures, we want to keep them safe. Why do we want to turn them on their side? Yeah, in case they puke. We don't want them to aspirate. But like I said, we don't want to put a tongue blade in their mouth. We don't want to put anything in their mouth during a seizure. A lot of times kids go apneic during seizures, so we're going to want to monitor the length of time if they do go apneic. And then we also want to monitor their CO2 to see, or not their CO2, their O2, their pulse ox, to see if they drop their sats during the seizure. Then we're also going to assess their postictal period. You know, how long does it take them to regain consciousness, kind of get back to their alert and orientated times 3, kind of get back to their normal. So our planning and implementation pretty much goes along with our assessment. You know, we're going to maintain airway patency when they're having a seizure, ensure safety, administer our right medications. And there's a lot of different anti-epileptic meds. Have you guys talked about seizure meds yet? Okay. So, a lot of times when you're at the hospital, you'll see Ativan. Who knows what drug class Ativan is?
Makes you chill out.
Yeah, it's a benzodiazepam. You'll see that as PRN that we give if they're having a seizure in the minute in the hospital. We can just give it IV. It works right away. Kids with seizure always have diazepam or Diastat. It's a rectal version of the benzo that they can give at home for prolonged seizures if they go home and have a seizure. Keppra or levetiracetam is another very common one we see. You guys don't need to know specific meds for seizures for your test. Phenobarbital, that's another big one that we see. So there's a lot of different seizure meds that we can use. Client education, family education, you know, we're going to teach them what to do if they have a seizure, when to call 911, how to keep them safe during their seizure, how to administer their medications, everything we just talked about. Craniosynostosis. There's craniosynostosis. Another mouthful word. So this is, it's always warm down here, it's like muggy. So this is premature closure of our cranial sutures. Usually happens in utero or before the first 18 months of life. When do our cranial sutures fuse normally? They usually don't close yet till closer to 2 years. Yeah. Huh?
It was 18 months.
It was 18, because I picked 2 years, I got it wrong.
Yeah, I was gonna say, is it 18?
Oh, your book says 2 years.
I should.
Well, I thought it was 2 years too, but she said, no, like 18 months.
Yeah.
Well, it's gonna
So
vary
2 years
from
for
kid to
sure.
kid.
Yeah.
Yeah, 2 years for sure, so I'd
Yeah.
probably say, that's interesting. It was that on ATI or something?
No, it was on the exam.
Oh, Micah's?
Yeah.
Oh.
I have a lot of records. We'll check that one.
Maybe I didn't pull it from the book. I don't know where I pulled that information from. Well, your fontanelles close by 18 months too.
Oh, it wasn't.
Yeah, it was
no,
fontanelles.
it wasn't fontanelles.
Okay.
Oh, whoops.
I was gonna say, because your posterior fontanelle is about 1 to 2 months, and your anterior is about 9 to 18 months. So, okay, so etiology, pathophys. Boys are affected about twice as often as girls. It's 1 per about 1,800 to 2,200 births, so we don't see this too often. Up to about 40% of cases have a known chromosomal disorder or chromosomal abnormality syndrome. Otherwise, we don't know what causes this.
How many cases have the chromosomal disorder?
40%. Like I said, those type of statistics you don't need to know for your test. They just give you so you have a general idea how often we see these things, because I've never seen this. So what do you think we worry about? Yeah, it says increased ICP, resulting in our brain damage. If they have that premature closure, they don't have that growth. So our assessment, so what we'll see is when one or more suture lines close prematurely, the bone continues to grow in a parallel direction to the suture line. So what we'll feel is this little kind of overgrowth or bump where the suture line is. And then we can have different brain shape or head shape abnormalities. So for our kids, we're going to monitor their fontanelles for premature closure. We're going to also measure their head circumference. So to fix this, we do surgery. Surgery is performed when there's multiple closures and we have that increased ICP or that chronic increased ICP. We need to do something about it, and then a lot of times it's performed for cosmetic reasons. So post-op, what are we going to do? Minor infection, neuro assessments, monitor for signs and symptoms of increased ICP, positioning, pain control.
How would you position them?
Whatever type of surgery, whether suture is, you want to maintain the skin integrity of the suture. Education evaluation. So congenital or neurological health problems. Am I still going too quick? Okay. So cerebral palsy, how many people have heard about cerebral palsy? Yeah, this is another very common disorder that we have. Cerebral palsy, or CP, is a group of permanent disorders of movement and posture caused by a non-progressive disturbance that occurred in the fetal or infant period. It's pretty much your first bullet on the slide. So a non-progressive motor disorder of the CNS resulting in alteration in movement and posture. So if something happens during utero or while the infant's being born, that usually causes some type of brain damage that leads to the CP. So it's characterized by abnormal muscle tone and lack of coordination. Depending on the kid, they can have a variety of different symptoms. And what extremity is involved can vary. Kids have a lot of limitations in activity. They can also have sensory, perceptual, cognitive, communication, or behavioral disorders. And this occurs in about 2 to 2.5 of every 1,000 live births. And there's 4 classifications, which we're going to touch on in a second. So for our etiology and our patho, like I said, most cases, about 70% of cases occur in the prenatal period, so before they're born. And most are caused by a brain insult, so there's some type of brain insult that happens. Causes, some examples of some causes can be trauma, hemorrhage, infection before, during, or after birth. Meningitis can lead to this, encephalitis, we're going to talk about those two in a little bit. Stroke, neonatal sepsis, so anything that can cause insult or damage to our brain can lead to cerebral palsy. So clinical manifestations, like I said, depending on the child, they can have a variety of different symptoms, and also depends on the extremities involved, what occurs with them, but usually we see abnormal muscle tone and coordination. So our spastic CP, we usually see hypertonicity or spasticity of muscle groups. The athetoid, we see kind of worm-like movements. Ataxic, they have disturbed coordination. But like I said, depending on the kid, they could have hypotonia, they could have hypertonia. What does diplegia mean?
Both sides of the legs.
Both legs.
Both legs.
Both legs are involved. Hemiplegia is where one side is involved. And quadriplegia is where all four extremities could be involved. So pretty much, like I said, manifestations vary by, where the insult is to the brain, each kid, how old they are. They can have contractures, muscle tone abnormalities, tremors. They have difficulty with fine and purposeful motor movements, troubles with balance, hyper or hypotonia, and they have lifelong delays and developmental delays that we see. Because this is a lifelong thing. Did anybody ever watch the show Breaking Bad? Walt Jr. has cerebral palsy, where you can see, yeah, in real life, where he has that issue with movement and coordination. So our assessment, this is where it's important to do our Denver 2 assessment, because we're going to notice that these kids are not hitting those developmental milestones that they should be hitting. Diagnosis is usually based on our clinical findings of our delayed development and decreased or increased muscle tone. They could have absence of expected reflexes, or they could have reflexes that go beyond the expected age. Some can have physical symptoms that include altered speech and difficulty swallowing. Some have visual and hearing deficits, and a lot of kids with cerebral palsy do have seizures as well. So our planning and our implementation, like I said, with each kid, it's different. Each kid, our plan is going to be different because each kid has different symptoms. Each kid has different progressions of this disease. So no matter what's going on, we want to promote optimal development. We're going to make a patient-centered care plan for this child and really promote optimal development. We're going to use our Denver 2. We're going to identify delays. We're going to provide adequate nutrition. Some kids are catabolic, where they need those extra calories. They burn calories quicker. If our kids, if they have feeding or swallowing issues, they may have a G-tube. So, we're going to teach family about the G-tube. Maintain skin integrity. A lot of these kids have braces and mobility devices that they use, that we're going to monitor their skin integrity. Promote physical activity. We're going to, usually physical therapy or occupational therapy are involved with these kids, because we're really trying to make sure we get them to as normal level as possible. Promote safety, you know, we're gonna watch for those seizures, make sure they're safe. And if communication's involved, we can do a communication board, you know, we can do a speech therapy, we can do, this is a team support. There are some surgical procedures and medication therapy. A lot of these kids get contractures. You guys know what contractures are? Those of you who are like at Walter Lawson's can see it a lot where, you know, they're not using that extremity how they should be, then a lot of times you can see them, or as often that you can see them kind of contract up and they get tight and it's hard to, or we have to go in and we have to release those tendons, release those contractures. Another one that I've only seen in little kids that we've taken care of at Lawson's is the implantation of an intrathecal pump where it has baclofen in it, and these kids have muscle spasticity, so baclofen helps decrease those muscle spasticities. Whereas the pump that we place inside them that kind of constantly gives them this medication to help decrease with that spasticity of their muscles. Hydrocephalus. So we've seen this a few times this semester on Peds, right? Hydrocephalus, yeah. You had it and then Brittany had it. So this is characterized by an imbalance between our CSF production, our cerebral spinal fluid production, and absorption, resulting in enlarged ventricles and increased ICP. So for some reason we're either making too much cerebral spinal fluid and it's all collecting in our brain, or there's something going on where we're not, usually there's something going on where we're not draining it how we should be. And if untreated, if we have too much, it can cause brain damage. So who are we more worried about with hydrocephalus?
Kids with their suture already closed.
Yeah, our older kids, their sutures. Remember, our infants, they don't have those sutures closed, so they have a little bit more space to expand. Our older kids, where it's already fused, they don't have that. What are signs and symptoms of increased ICP? Headaches, alterations in mental status, vomiting. We're going to go through a few more. Bulging fontanelles, seizures. So etiology and pathophysiology. Congenital. This is when the blockage occurs prior to birth. They're born with it. It's a congenital defect. Has anybody ever heard of Chiari malformation? My mother-in-law actually had this, kind of where your brain kind of sits back and kind of puts pressure on your brain stem, and that can lead to increased hydrocephalus. Acquired occurs at birth or sometimes after. Something happens that can lead to this. So meningitis, trauma, an intraventricular hemorrhage, brain tumor. Something that we acquire that can lead to this. Idiopathic, usually everything's idiopathic, we don't know what causes it. So our clinical manifestations, like we said, are infants, they're going to be irritable, large head, vomiting, lethargy, those sun-setting eyes. And this is kind of a picture of those sun-setting eyes, where their eyes get really big, but you can kind of only see half of their pupils. Older children, headache, vomiting, lethargy, double vision, sun-setting eyes, all those things we talked about last week. Bless you.
Bless you.
Yeah. So assessment, what are we going to monitor for? Neural assessments, yeah, and we're looking for signs and symptoms of what? Increased ICP. What do you think we want to monitor on infants? Head circumference, yeah, we want to make sure their head's not getting any bigger. Split cranial sutures. bulging fontanelles.
When we see that,
Huh?
we'll see the bulging fontanelle.
Mm-hmm. The way you feel them, instead of being nice and soft and normal, they're popping out. Toddlers and kids, we already talked about a lot of the signs and symptoms. Diagnosis is usually confirmed using a CT or MRI, because usually we have some type of obstruction, so we're going to identify where that obstruction is and why this fluid isn't draining out. So Brittany, what did they do for what did your kid have that had hydrocephalus?
What they do, they put tubes in, they just had to have this stuff drain out, but then I didn't work there when I moved to Shotton.
VP shunt, we usually put a ventriculoperitoneal shunt. So this is an insertion of a tube or a shunt, and it goes into the ventricles of the brain. They drill a little hole. In the hole, they put a little tube that helps drain out that CSF. There's a little, you can see right here, there's usually a little device that is our drain that when we get too much fluid, that clicks in and opens up and lets that flow out. So ventricular peritoneal shunt. This one then drains from our brain into our peritoneal cavity, our abdomen. And then our body just kind of reabsorbs and redistributes the extra fluid. There's also a thing called a ventricular arterial shunt, where it goes more closer to your heart, the atrium of your heart. I've never seen that one. The only one I've ever seen we do is the VP shunt. So this is shunting all that extra fluid away from the brain into another portion of our body, because these kids can't do that on their own.
From this picture, is the tube on the outside of the body, or is it?
No, I have a better one. So we drill a little burr hole into their ventricles, and this goes, and then sometimes they'll put another little incision behind their ear. The tube runs under the skin, and it runs down behind the ear, down the neck, into the abdomen. So this is all internal.
Okay, so we don't
If
see
they're
Amazing.
if their head's shaved or they don't have hair, you'll be able to see it.
the tube.
Yeah, and I think I have a picture of it on the next side
How
of
long
it.
do they need this for?
Forever.
Forever.
I have not seen. The only thing I've seen people come in with this is they're starting to show signs and symptoms of increased ICP again. So what does that mean? It's not working, or they have spiked temps. Something's going on. Either they come in and they have either an infection, or a piece broke off that they just need to put that back together. There's clogged. Something's going on that they have to go in and fix their shunt to help repair that. That usually this is lifelong, because they have a problem that they're not draining out their fluids. So pre-op, like we said, we're going to monitor for our increased ICP. Post-op, usually they say place them in a flat position to prevent rapid CSF drainage, because they say when they sit up that it can drain too much too quick. But try to keep a little baby or an infant, toddler in a flat position. Vital signs, neurological assessment. We're gonna watch our pupils, monitor for abdomen distension, accurate INO. And like we said, we want to monitor for shunt failure, or shunt not working. So we're either going to have increased head circumference, bulging fontanelles, those signs of vomiting, lethargy, those signs and symptoms of increased ICP because the shunt's not working, or we're going to have signs of infection. So here's a real life picture where you can see the shunt. Usually it's a little bit lower, about here, but you can see then the tube going down and around. But once they grow their hair back, you really can't see it at all. So what are we going to teach the family?
For the signs and symptoms.
Signs and symptoms of increased ICP. And so what is that showing? It's not working, yeah, so we're going to teach them signs and symptoms of malfunctions, or shunt malfunction. Some kids do experience seizures after placement because we're taking a lot of fluid off very quickly, that we're gonna teach parents seizure precautions. You know, some kids, if their hydrocephalus was severe enough, if we didn't get in there and fix it quick enough, they could have brain damage. So we're gonna continually to monitor these kids, you know, watch them developmentally, and provide referrals and services as needed, depending on what and if we find anything.
So sunsetting eyes aren't permanent, it's just if it's it's just intrapressure.
Yeah, it's from all that extra fluid that they have.
So it'll go away once
Yeah.
it goes down.
I'm kind of skipping over our like I did last time, have a couple times, the evaluation and education, because a lot of it sums it all up. You know, what are we gonna evaluate on those kids? Their shum's working, they don't have signs and symptoms, increased ICP, they don't have infections, you know, things like that. Neural tube defects. So have you guys heard of these too? These occur during our first trimester of fetal development. Neural tube defects include our spina bifida, our myelodysplasia. When I say the word spina bifida, and myelodysplasia, there's a variety of different types of neural tube defects that are encompassed underneath those names, and we're going to go into each one on the next slide. So this is a defect that occurs along our spinal column, and it can occur anywhere along our spinal column. Our etiology and pathophysiology. What have we found that neural tube defects are associated with? Yeah, folic acid, lack of folic acid for moms during that first trimester. Some environmental factors have been implied, such as chemicals, excessive alcohol use, medications, some seizure meds. There's been known to have some genetic factors. I had a student last semester, her family had an issue where they didn't break down folic acid properly, so they're a higher risk for these neural tube defects because their body didn't break down and absorb folic acid how it was supposed to, which was something I knew I'd heard from for the first time too. So clinical manifestations, so the degree of disability and clinical manifestations depends on where the defect is. This is going to make a little bit more sense when we get to the next slide. The higher the defect on our spinal column, the greater the neurological dysfunction that we see.
Can you say that one more time, please?
It's right here, your bullet. The higher defect, the greater the neurological problem.
I'm sorry, Erin, when you say that, you mean higher up the spinal column?
Yep. And this is, I don't know how to put this on my slides. The next slide's gonna make more sense with this. A lot of times we see kids have this affect their bowel and bladder use, where they have, a lot of times you'll see neurogenic bladder. Hydrocephalus is common with these kids. And a lot of these kids can have motility problems, intellectual disability, visual impairment, because, I'm going to go on the next slide because it's going to make a lot more sense. So these are different types of spina bifida, or our myelomeningocele, where we have 5 different types we're going to touch on. So the first one is ancephaly. A-N-C-E-P-H-A-L-Y. This is no development of the brain above the brainstem. So this is a picture of ancephaly, where you'll pretty much see the face and the head kind of be flat because there's no development of the brain above the brainstem.
Can you spell that one?
A-N-C-E-P-H-A-L-Y. Next one is encephalocele. E-N-C-E-P-H-A-L-O-C-E-L-E. And that's this one, where we see the protrusion of our meningeal tissue, or our meningeal covered brain through a defect in a skull. So we can see a little sac that covers and contains either meningeal tissue, portions of the brain that happens in a defect in the skull. The next one is spina bifida occulta. So this is our normal. This is a picture of what our normal spinal column should look like. In our spina bifida occulta, you can see our cerebral arches fail to fuse, so there's an issue where we don't have fusion right here. But there's no herniation of our spinal cord or meninges. What are meninges?
It's around the nerve tissue.
Yeah, that fibrous membrane that covers our brain and lines our vertebral canal. Many times with spina bifida occulta, we don't see too many. They may not have any loss of function. Then the next one is meningocele. So like I said, all of these are encompassed under a broad term called spina bifida or myelodysplasia. But then there's specific different ones that can occur. So meningocele is, you can see protrusion of a meningeal sac filled with our cerebral spinal fluid through a vertebral defect. So we have that vertebral defect, or we didn't have the fusion, and now we have this sac that's filled with CSF fluid.
Can you repeat that definition again?
Protrusion of a meningeal sac, filled with cerebral spinal fluid through a vertebral defect. So the sac contains meninges and CSF, but it doesn't contain any of our spinal nerves or our spinal column or spinal cord. The last one is myelomeningocele, this one. So they kind of get worse as we move along. So this is, once again, we have that failure of our posterior vertebral to fuse. So we have that protrusion of the sac again that's filled with our CSF, but this one also contains our spinal cord and our nerve roots through that vertebral defect. Sometimes we can see CSF leakage.
You said it's filled with spinal cord and nerve?
CSF and our spinal cord and nerves. So like I said, with this, the higher the defect, the more neurological problems we see. Because of it affecting our spinal cord and how involved it is, a lot of times what we see with these kids is, below the defect, they lose innervation, our nerve movement. So we'll see a lot of issues with legs. That a lot are in wheelchair because they can't walk, they're immobile in their legs. We see a lot of issues with their bowel and bladder. They have what's called neurogenic bladder. You guys ever heard of a neurogenic bladder? They lose that innervation in their bladder, so they can't feel when their bladder's full. They can't go to the bathroom on their own. So they have to be straight cathed every 6 to 8 hours, depending on what the child's regimen is. So we're going to go on to our assessment. So this is an example of an encephalocele, and this is an example of a myelomeningocele. So assessment, prenatally, a lot of times we can see this on ultrasound. We can see if they have problems or neural tube defects on the ultrasound. Another test that we can do is alpha-fetoprotein. On the mom, we'll draw alpha-fetoprotein levels, and if they're elevated, they can show that there's possibly an issue with neural tube defects. What else do elevated AFPs show? Yeah, alpha-fetoprotein. That's also one of our tests for Down syndrome too, that we can see if they're elevated. They might possibly have Down syndrome. If we don't catch it prior to, it's going to be obvious at birth. With the spina bifida occulta, the one where we just have this non-fusion, but we don't have a sac or anything, I've talked about that Ballard assessment that we do when a newborn is born. One of the steps you do is you flip them over and you run your finger down their back. Make sure that their spinal column is fully formed, all the way intact. Sometimes what you'll see right below or right above, in the sacral region is a little dimple or a little tuft of hair, and that's all you'll see. But that could be that could tell us that they have the spina bifida occulta. If they have a sac like this one, what do you think we want to do?
Protect it.
Yeah, we're gonna protect that sac. What do we usually do to protect it? Moist dressing, moist sterile dressing, maintain the skin integrity, so that's why this baby is put on his tummy and he's not put on his back. We can put them on their tummy on their side, but we don't want to put them on that defect. We're going to monitor for leakage. So we're going to also assess with these kids the level of sensation below the defect, because like I said, a lot of these kids below that defect and on, because all that spinal column and those nerves are in that defect, you see a lot of problems with their legs and issues below that defect. So we're going to see what their functioning is below that defect. Measure head circumference. Why do you think we want to measure head circumference? These kids have a high risk of hydrocephalus. So we're going to monitor their head circumference to make sure. Planning and implementation. Like we said, we're going to, the defect of the sac is repaired within the first 24 to 48 hours. We want to reduce the risk of infection. Pre-op, we're going to focus on, maintaining that sac integrity, keeping it free from infection. We talked about positioning and keeping it moist and sterile with the saline soap dressing. Avoid contamination with urine and bowel. We want to keep it nice and clean. These clients with myodysplasia, like I said, myodysplasia is kind of the broad term for all of these neuro 2 defects. These kids have a higher risk for latex allergy. So we're going to monitor them for that. We talked about the neurogenic bladder, where they may not be able to pee on their own, so they have to have straight calves. So if they're constantly being straight calf, what are they more at risk for? UTIs. That sometimes you'll see these kids just on a low dose antibiotic just to prevent UTIs. They can also have neurogenic bowel, where they kind of don't have as good functioning of their bowel. So we're going to work with the family, to provide a bowel management, high fiber diet, fluid intake, try to set up a regular bowel evacuation pattern for them. May need some laxatives if it's severe enough. If they have issues with their legs and movements, who else do we want to collaborate with? Physical therapy. A lot of times these kids have wheelchairs or crutches, braces, different things to help them mobility-wise, depending on how severe they're affected. Okay, let's take a 5-minute break. Meningitis. Every time there's an itis, what does it mean? Inflammation. So inflammation of the meninges. Most common infection of our CNS can be caused by either bacterial or viral agents. So what are our meninges? Kind of talked about this last slide.
It's our covering.
Yeah, it's what covers our brain and our spinal cord. So this is also kind of treated as a medical emergency in infants and kids. So our etiology and pathophysiology, like I said, it can be viral or bacterial. Each contain a variety of different, agents that can cause it. Viral usually resolves in 3 to 10 days spontaneously. Bacterial
You said resolves?
Yeah.
Sorry.
3 to 10 days spontaneously on its own.
3 to 10.
Bacterial is a little more serious and more fatal than our viral. We worry more about bacterial. The most ones that I've seen is group B streptococcus and E. coli. So where do we see group B strep? Moms. A lot of moms naturally, a lot of people naturally have it in their vaginal canal or down in that region that it can spread. That's why every mom is tested for group B strep prior to that it can spread to the baby. We've had some babies come in a couple weeks after mom has the baby showing any signs and symptoms of meningitis, and it comes back as group B positive or group B strep. These can occur secondary to another infection, such as otitis media, pneumonia. So where the organism, whatever infection's going on, the organism spreads to our CNS and it gets up to our brain. Clinical manifestations. These vary again by child's age, the pathogen, the length of the illness, before diagnosis. Onset can be sudden; it can develop over about 1 to 2 days. Infants, we're going to see fever, changing in eating patterns. You're going to be irritable. You're going to have bulging fontanelles, because this can lead to our hydrocephalus again. Vomiting, diarrhea, they're going to be fussy.
Can you repeat those?
Fever, changing in feeding patterns, vomiting, diarrhea, fussy, irritable, bulging fontanelles. Children, once again, fevers, altered level of consciousness, vomiting, headache, and nuchal rigidity. What is nuchal rigidity? That stiff neck, that neck pain. They have that stiff neck. A lot of older kids, they come in, they have nuchal rigidity, where they have that stiff, painful neck and headache. And once we hear that, we hear that neck pain, we're like, oh, okay, we're gonna think meningitis.
Can you spell that?
Nuchal. Rigidity.
And you said vomiting, nuchal rigidity, fever.
Yeah, pretty much to sum them up: severe headache, stiff neck, fever, bulging fontanelles, altered mental status. We got vomiting. Yeah, your question?
Yeah, so the bacterial is dangerous, but the virals, unless you're like real old or young, it's not.
We're gonna go more into that when we get into treatment, but our bacterial is more severe. We worry more about bacterial than we do viral. Viral usually resolves in about 3 to 10 days on its own. So bacterial is more serious, yeah.
I'm sorry, you said the onset can be sudden or it can
Yeah, sudden. It can be sudden or it can develop over the time. Some other clinical manifestations. These kids just look sick, they feel sick. In older kids, we can have what's called a positive Koenig sign. That's this one where we lift up their leg and we try to straighten their leg, and we feel that pressure. We can't straighten their leg all the way. The knee is flexed, so we can't get that resistance is noted, and pain is felt, and that's a positive Koenig sign. The other one is Brzezinski's, where we'll see if we flex their head up, then their knees also come up with that as well. And those are both positive signs for meningitis. A purple rash, I have a picture of this purple rash on the next slide, is a septicemic rash. If it stays red and it doesn't blanch, it's a sign of the septicemic rash, and this is a late sign and symptom of meningitis. We do not want to see that. But you know, this is head involved, so we can think of all our neuro things, you know, headache, malaise, lethargy, photophobia, you know, they're sensitive to light, all those things. So, our lab data. A lot of times we do a lumbar puncture. What's a lumbar puncture? Yeah, spinal tap, where we go in and we pull out CSF. If it's bacterial, what are we going to see?
Cloudy.
We're going to see bacteria in our CSF. Elevated white blood cell count. We're going to do blood cultures. We want to ID whatever is causing this problem. We want to figure it out. Planning implementation. We're going to provide an environment that's going to minimize ICP elevation. You know, this is our head, this is things going on with their head, they have a lot of sensitivities. You know, we're going to do quiet. We're not going to have them, you know, flinging their head around a lot. If it's baby, you know, we're going to try to keep them quiet and calm. Avoid neck extension. Monitor neurological assessment. We're going to assess pain and administer pain medications. Most of the times, if kids are admitted with viral meningitis, they're only admitted because of dehydration and pain. So we treat pain control and we do IV fluids. Because of everything going on, they get dehydrated and they have a lot of pain. So we're not treating, we don't treat the viral meningitis, but we treat the symptoms of it. Children with bacterial meningitis, they need to be isolated. We can take them off isolation. My group, when can we take them off isolation?
After 24 hours.
24 hours after antibiotic therapy. Once we give them the antibiotic that covers their whatever agent is causing the problem, after 24 hours, they can be off isolation therapy.
That's you.
Medication therapy, you know, for our bacterial meningitis, we're going to do our IV antibiotics. Treatment, usually about 7 to 14 days. Some of these little infants that come in, they get the whole septic workup, and then they're there for 2 to 4 weeks on antibiotics because we can't figure out what's going on. We're going to give them the flu vaccine as preventative measure. Another big reason we give our our H influenza vaccine, because that's one of our agents that can lead to meningitis. So this is a picture of that purple rash that's showing that this kid is septic and this kid is really sick and we need to do something about it fast.
Is that with both viral and
This is our bacterial. Let's see if it's our bacterial. Make sure I'm telling you right. I want to say it's with bacterial because that's where we have the high risk of becoming septic. And like I said, viral usually resolves in about 3 to 10 days on our own. We usually don't treat. Encephalitis. So everyone's good on meningitis. Meningitis we see a lot. So when you're up on peds, you'll probably see it. Yeah.
So, I don't know if I missed it, but how do you tell apart between viral and bacterial? Like, do you do some sort of a test for it?
We do our lumbar puncture, and we pull out our CSF. Bacterial, we're going to see bacteria in the CSF, elevated white blood cells. We also do a blood culture. Blood culture is going to help us identify the organism and show us what is causing it.
I guess the signs and symptoms are the same for both viral and meningitis.
Yeah, a lot of
It's
times
just-
they're the same signs and symptoms.
Okay.
Like I said, the main ones, you know, are a lot of our neural things, that positive Kernig's, Brzezinski's, headache, nuchal rigidity. Headache, like I said, our older kids, a lot of times they come in with that headache and that nuchal rigidity. Infants, they'll be irritable, fussy, tense, won't be eating as well. You know, the parents can know something's going on. Encephalitis, so this is inflammation of our brain. So meningitis, inflammation of the meninges. Little step further is encephalitis is inflammation of our brain. Etiology and pathophys. Once again, it can occur by a primary infection, where an organism, whether it be virus, bacterial, fungal, parasite, passes through our blood-brain barrier. Herpes simplex 1 is the most common one during our prenatal or our neonatal period, not our prenatal. So once again, usually the infection begins somewhere else in the body and it spreads. West Nile virus is another thing that can lead to encephalitis. Prognosis begins on the level or the degree of CNS involvement. And we can have what's called neurological sequelae. Sequelae is when we have an injury or insult and then we have effects from it after. So we're going to talk about this when we get to concussions. Or if you have a head concussion and it's severe enough, you can have headache or dizziness and headaches, symptoms for months after. So clinical manifestations, once again, fever, irritable, severe headaches, bulging fontanelles, change in our mental status, which can lead to, they can become disorientated, confused, personal and behavioral changes, motor dysfunction. We can also see that nuchal rigidity, that photophobia, that Koenig sign, that Brzezinski sign with this as well. And if they have enough irritation, we can see seizures.
Can see what?
Seizures. Seizures.
You can see both or just the Brzezinski sign?
You can see both of them again
Okay.
with this one.
Mm-hmm.
So we're monitoring the vital signs, their respiratory status, their cardiac status, seizure precautions. Most of the time these kids are in the ICU because we want to keep a close eye on them. If they're immobile, we're going to watch their skin integrity. Once we figure out what's causing it, we're going to administer our medication. So if it's bacterial, we're going to do antibacterial. If it's viral, we can do antiviral. Oh, somebody's getting a call. Okay, Ray's syndrome. So we touched on this a little bit last year. Does anybody remember this at all? Yeah, this is the one with our link to aspirin. So this is acute metabolic encephalopathy of childhood. Pretty much summing up, this is a rare condition that leads to serious swelling of our brain and our liver. We have fatty degeneration of our liver that leads to dysfunction, liver dysfunction. So what we usually see this with is kids who who are recovering from a viral agent, such as chickenpox. What causes chickenpox? The varicella virus.
Yeah.
They're grouped together, but the varicella. So what we link this with is kids recovering from usually the flu, and then parents try to treat it with aspirin. This is why we never give kids aspirin. So what we usually see with these kids is they have vomiting and lethargy, mental status changes, well, they'll be confused, leading to progressive unresponsiveness. It progresses to increased cerebral edema and neurological dysfunction. So our final stages, we can see seizures, coma, loss of our deep tendon reflexes, and respiratory arrest. seizures, coma, loss of our DTRs, and respiratory arrest in our end stage if we don't do something about this. Hypoglycemia, that's one of our first signs. Abrupt changes in level of consciousness. We'll see a history of the child recovering from a viral illness. What do you think is going to happen to our liver enzymes? Our liver enzymes are going to be elevated. Ammonia levels are going to be elevated. Dog hair all over me. We can do a liver biopsy. It's going to show fatty deposits because we have that fatty degeneration of our liver. And this is sometimes used to confirm diagnosis. So for our planning implementation, these kids we're going to monitor ICU. We're going to monitor, for cerebral edema. So we're going to do frequent neurological assessments, vital signs, that Glasgow Coma Scale. We're going to monitor their labs. Monitor their ammonia, their blood sugar,
Liver function.
all our liver functions. Medications, we can give medications to reduce swelling, so like our steroids. We can do mannitol. What is mannitol?
Decreases blood pressure.
Yeah, that was our osmotic diuretic. That's the one that worked in our brain to help decrease our cerebral edema. They may need meds to help control seizures if they lead to seizures. Everyone good on Ray's syndrome?
Mm-hmm.
Tell me if I'm going too fast. I just want to hit the main things and get you guys out of here. Guillain-Barré syndrome. Has anybody heard of this? Yeah, I've never seen this in a kid, but it's a pretty interesting thing. So this is acute inflammatory disease or inflammatory peripheral neuropathy with acute onset, and it progresses in an ascending pattern. So what does that mean? Huh?
It's going from the feet.
Yeah, it goes up, feet up. So we'll see symmetric motor weakness progressing from our feet up. It's an acute demyelinating disease of our nervous system. So like I said, we see that ascending paralysis where weakness occurs in our lower limbs and slowly works its way up to the rest of our body. We'll have a complete loss of our deep tendon reflexes. And if it's severe enough, it can also affect the respiratory system. Respiratory system. Usually after a certain period of time, these individuals fully recover. They get everything back, but it can take up to a full year to fully recover. Some even see permanent lingering effects of the disease if it was severe enough. So our etiology and our patho, thought to be an abnormal immune response to an infectious organism that damages our peripheral nerves. So what we usually see with this one is the onset usually occurs within 1 to 3 weeks of a respiratory or a GI illness. So the progression of that paralysis, like I said, occurs over about 1 to 2 weeks. And a majority of clients recover over about 4 to 15 months with no long-term or no residual disabilities. About 2 to 15 months. So So our clinical manifestations, we're going to see that for infants, that rapid severe hypotonia, respiratory distress, irritable and possibly difficult to feed. Our older kids, initially pain, numbness, paresthesia, that weakness in our limbs, weakness is bilateral, progresses over days to 4 weeks, and maximum weakness is usually seen in about 2 to 4 weeks. What happens to our deep tendon reflexes? Yeah, they're either very diminished or absent. A lot of times our respiratory and cranial nerves, they may not be affected. A lot of times they're not affected. But we worry if they start having problems swallowing or difficulty breathing, then we worry about them being affected. So we're going to monitor them for that. So assessment, what are we going to do?
The reflex.
Yeah, we're going to monitor for that progressing paralysis, or monitor for weakness, muscle weakness, paresthesia, deep tendon reflexes, respiratory function, can they still swallow and eat okay? Medical diagnosis is confirmed with a lumbar puncture, and also what's called an electromyography. This is not an EMG, this is on your test, but an EMG is where they put little kind of pins in different muscles to see if your muscles react how they should be. A lot of times they'll do it for things like if they're trying to diagnose you with carpal tunnel or things like that. Planning and implementation, we administer IVIG, IV immunoglobulins. What do immunoglobulins do?
Immune system boost.
We're giving, it's healthy antibodies, it's antibodies, right? So we're gonna give them healthy antibodies to help fight this disease. And then we can also give them immunosuppressive drugs, because we think that there's a link to possibly immune system reaction with this. Rest of our care focuses on the immobility. We want to make sure we take good skin care, monitor for complications. We're going to begin that rehabilitation process right away to help lessen that possibility of permanent disabilities. Provide emotional support. Any questions on Guillain-Barré? Barré, I don't know if I say it right. Probably don't. Okay, head injuries. The next few slides are pretty straightforward. So head injuries. Any trauma to our head, right? A lot of kids have head injuries. I've had kids fall out of windows into second-story windows. Abuse. There's a lot of different things that can cause head injuries. What do we worry about with head injuries? Our cerebral edema, increased ICP. So like we said, major cause in young kids is falls, child abuse, shaken baby, motor vehicle accidents, sports-related accidents. We had a little baby that the parents had him on the counter and, one of those little buzzing seats, and they just buzzed right off the table. We have two categories. We have primary injuries. So these develop at the time of the trauma when the initial tissue damage takes place. So at the time of injury, we see an increased ICP and loss of consciousness can develop. Secondary brain trauma develops as a result of the body's response to injury. This response can result a few hours to a few weeks later after the injury. So the brain damage that occurs is usually secondary to hypoxia, edema, hemorrhage, increased ICP that can lead to irreversible brain damage if we don't fix it. So for our assessment, what are we gonna do with kids that have head injury? Neurochecks, vital signs. Watch for signs and symptoms of increased ICP. Watch for that Cushing's triad. What was that Cushing's triad?
The blood pressure.
Cyanosis, or no?
Bradycardia, irregular respiratory, and our increased blood pressure. That increased,
Widening.
yeah.
What's that called again?
Cushing's, or not Cushing's triad. Yeah, Cushing's triad.
What did you say before?
Huh?
What did you say?
Increased blood pressure.
It's the widening of the
Remember we
blood
talked about it last
pressure.
week? That widening of the blood pressure, our bradycardia, and our irregular respirations. That's a late sign of our increased
Okay.
ICP. Planning implementation, we're gonna monitor neurologically, yeah. We're gonna monitor their O2s, their respiratory status. We're gonna prevent complications. Mannitol medications, we can give mannitol if they do have that cerebral edema to decrease that increased ICP. A lot of kids that come in with head injuries, like I said, with that secondary, you'll see them initially be fine and then later on develop symptoms. So I always tell parents, you know, if after a few hours or tonight, your child's not acting normal, they're hard to wake up, they're vomiting, anything's going on, you know, bring them back in. A lot of times we watch them for 24 hours just because of that problem. Skull fractures. Fracture of any of our 8 cranial bones. What can cause a skull fracture? Yeah, any type of trauma, any force to the head. We have different types of skull fractures. Linear is breaking the continuity of the skull. So here's a picture of our linear, where it's just a little, almost straight line. Usually symptomatic. Depressed. This occurs when fragments of the skull separate from the rest of the skull and push downward into the brain. These require surgical intervention to prevent brain damage. One time when I saw one of these was when I was in nursing school and was a student nurse at doing our rotations at Children's, and this little infant came in and was at daycare, and I want to say it was about a 2-year-old, got a hammer and started just drilling her head with a hammer. So she had all these compressed fractures in her head that they had to go in. Luckily she had no brain damage. I don't know how she didn't have any brain damage, but. And then the last one is basilar. This involves a fracture at the base of the skull. So where you see it kind of down here at the base of the skull. Huh?
How do you spell that?
B-A-S-I-L-A-R.
Thank you.
You're welcome. So what we see with this one is CSF leakage from our nose and our ears. Periorbital ecchymosis. So what is that? Those raccoon eyes. Or bruising behind the ears. What's called battle sign. So here's another picture of that battle sign with our basilar fracture.
What are raccoon eyes called?
Periorbital ecchymosis, just that bruising around our eyes. So if we see leakage from, CSF leakage from their nose or ears, what do you think we're going to want to do to correct that? What do you think that's a sign for us to do? Surgery. Yeah, we gotta go in. That's one of our signs for surgical correction. If we're seeing that CSF leakage, we wanna go in and fix that.
That was a trick question.
I don't do trick questions. So assessment, what are we gonna assess for?
Level of.
Yeah, we
Is
can
the SF leakage, are we leaking, their level of consciousness, their neuro assessment. Treatment usually involves neurosurgeon consultation. Linear fractures, those usually heal on their own without any type of intervention. Are decompressed, usually need surgery as well. And then, our routine post-op care, neuro checks, monitor for ICP, vital signs, pain management, infection prevention, medication therapy, antibiotics if they have to have surgery, and then depending on what caused the problem, the fracture, they could need a tetanus booster. Contusion. Am I going too quick? Like I said, I'm trying to hit the big things, the things that I really want you to know, and then we'll breeze over the other things. So, what is a contusion? A bruise to our brain tissue, caused by small blood vessel leaks. Contusions are more serious than concussions. Most often caused by impact to the head. So, car accident, a fall, sports-related accident. This is our coupe contre coupe. That we see this picture where, we go forward, it hits the front, and then we whip our head backwards and it hits the back. So our etiology and pathophysiology, I have it listed right up there for you. So our assessment, symptoms vary depending on the child, but they may have decreasing level of consciousness. They can be very minor where we have very little symptoms or damage to the brain, or they can be very severe. They can lose consciousness. More severe ones can lead to brain swelling, which leads to further brain damage. Other symptoms can be attention loss, memory loss, attention problems, difficulty with motor coordination. So for our planning implementation, we're going to monitor them neurologically, we're going to monitor them for signs of complications, and we're going to observe them for long-term complications as a result from the injury. We're going to teach parents what those complications are, teach them signs and symptoms to notify us about. So a concussion is a mild traumatic brain injury. What do you think a cardinal sign or symptom of concussion is? Loss of consciousness. Usually involves some type of transient loss of consciousness.
Right after the trauma, not later.
So we usually have a blow to a head.
Well, you don't have to lose consciousness to.
You don't always lose consciousness, but when they do, losing consciousness, loss of consciousness is one of our cardinal symptoms of it. Usually there is a brief period of loss of consciousness.
Yeah, because football players, they get tested all the time, but they just run off the field confused maybe.
Right?
Right?
They usually black out for like a second
a
or
little
two,
bit.
and then they,
Yeah, and I think they're getting more on top of that because they're,
they have to take tests every week right now.
well, I know I went to a PEDS forum this summer and, our trauma nurse practitioners came in, and now there's, with kids with, especially football, like that head trauma, sometimes there's bleeds or something going on and they're missing them. And then you'll see them go back out, get another head trauma, and all of a sudden pass out and have, you probably not make it, a lot of times not make it. There's a lot of stories online, showed us the story online, it was really sad. because there's a bleed in there. And they, checked them, they were fine after, let them go back out. So I know they're getting a lot more on top of our head traumas, especially in football and stuff. It may, like I said, it may not cause loss of consciousness, but a lot of times we do, and that's one of our big symptoms of it. Child may have headaches, dizziness, photophobia. Parents could report subtle changes in personality. So remember, a concussion is a mild traumatic brain injury. Usually results from a sudden blow to the head, where a contusion is that bruising on the brain. Both are due to head trauma, both are common, both are serious, but remember, our contusion is a little more severe.
Can you see the vomiting in either one?
Yeah.
Okay.
Anytime that we can affect our brain and have problems with our brain swelling, with ICP, we can have vomiting and problems, yeah.
Can you see bruising on a test, like MRI or whatever test?
If it's bruising, then it's a contusion.
But can you see it, like if a kid is taking for a test, can they tell that the brain was actually bruised?
I would think, yeah, I would think so. We don't ever get to look at the CTs and MRIs. So assessment, clinical manifestations, physical, like we said, headache, sensitivity to light or noise, visual problems, nausea, vomiting. Cognitive, they may feel foggy, have difficulty remembering things, difficulty concentrating. We can see emotional effects, irritable. They can be sleepy, drowsy, have more difficulty falling asleep. And then we can have what's called a post-concussive syndrome. This is what I was talking about earlier, where it usually occurs in kids under 3, where at the time of injury they'll be stunned and there'll be no loss of consciousness, but then later you start seeing signs and symptoms. Maybe they become pale, clammy, lethargic, vomit, where we don't see symptoms for a few hours after the initial injury.
Is that why when you have a child and they say they fall and hit their head and kind of don't respond, that's bad?
And then it's not, they might be fine, but what I always say, even when we have the kids that come in with head trauma and they're there for 24 hours observation, what I always say is if they start acting different, let me know. If they get more sleepy, if they're just not acting right, something's going on, let me know right away. So there are 3 levels of concussion severity, grade 1 through 3. So grade 1, child has transient confusion with no loss of consciousness, and a duration of abnormal mental status for less than 15 minutes. Grade 2, child has transient confusion with no loss of consciousness again, but the duration of abnormal mental status is more than 15 minutes. And then grade 3, child has loss of consciousness for a few seconds to several minutes or longer. And the big thing about our grade 3, remember I talked about that sequelae before, where you can develop symptoms for a period after. These kids can experience dizziness for more than 6 months after the concussion. So if they have a severe concussion, it's normal for them to possibly have dizziness for up to 6 months. So planning and implementation, usually we observe these kids. If it's severe enough, parents can watch them at home for 24 hours, or when they come in the hospital if it's severe enough and they're admitted for observation, we watch them for 24 hours, do neurological assessments, decrease their physical and cognitive activity the first couple days just to let them fully heal. symptoms can disappear right away, but like I said, they could last up to several weeks. Okay, and then we have two types of hematomas that we're gonna go through very quickly. We're gonna hit the main things, I'm gonna get you out of here. So a subdural hematoma, one of the major sites for bleeding or hemorrhage with a head injury. This develops slowly, spreads thinly and widely, results from, fall, birth trauma, shaking, often seen in infants. Our assessment, those signs and symptoms of increased ICP because we have bleeding going on, right? So vomiting, drowsiness, increased head circumference, bulging fontanelles, personality changes, headaches. If the subdermal hematoma is acute, it usually just resolves in 48 hours on its own. Oh, sorry, I said that wrong. If it's acute, we usually see symptoms within 48 hours. Chronic, it may take up to several weeks until we see symptoms.
24 or 48 hours.
Yeah.
Is it a real week later? For chronic?
Acute subdural hematoma is usually symptomatic within 48 hours. Chronic, it may take up to 2 weeks before we see symptoms, where it slowly develops. And we confirm a subdural hematoma by CT. Planning and implementation, neural assessment, level of consciousness assessment. Like I said, a small subdural hematoma may reabsorb itself. Larger, we may have to go in and do what's called a burr hole, where we drill a little hole in their brain or their skull and evacuate out the extra fluid. So post-op, vital signs, neurological, level of consciousness, all those fun things. Epidural hematoma. So this is where the bleeding accumulates between our dura and our skull. It's not as common as subdural. But the accumulation of blood applies force down onto the brain, and the bleeding is usually arterial and onset is rapid. So assessment, once again, classic symptom is initial loss of consciousness, and then they regain it. Then they can lose it again. Irritable, headaches, symptoms can resolve within minutes to hours of the injury. We're going to diagnose it with a CT, and if we don't treat this, it can be fatal. So that shows the difference between our epidural and our subdural in there too. So planning implementation, we're going to do those burr holes again to evacuate. Craniotomy may be required to go in there and make sure we get the bleeding out. Rapid recognition and treatment leads to better outcomes. And nursing care is very similar to all of our other types of head injuries and our surgical procedures. Any questions on those?